And I want to just make a point that Janet made in the chat box, and I think Jaime followed up, is, what Brenda said or Neil had mentioned is, I was in another meeting earlier this week with physicians, and we talked a lot about COVID, and they phrase it as we're transitioning into COVID recovery. And what I mean by that is, this is now the opportunity to really go back to all the other things that we kind of put on hold and pause during COVID while we were trying to manage and put all of our efforts in it. And, with Janet saying that COVID, Jaime saying COVID increased disparities and, hypertension control dropped during the pandemic. I look at that more as an opportunity now, like now that we're being able to refocus our efforts as we go into COVID recovery phase. How does that look, and what's the role the Roundtable can play systemically and help support all the great work that is happening on the ground? So that's more of a comment than a question, but feel free if anybody wants to come off mute, and if everybody wants to come off mute or just comment on that. Okay, it's clearly Friday. So with that, we'll go into our group discussion. And, again, I want to invite anybody who is not a member of the Roundtable to, join us. We are growing exponentially and continue to want to grow and scale up our efforts. And again, continue to want to support all the great work that's happening on the ground. So I'm going to ask you all now, and feel free to chat in the chat box, come off mute, but, looking back on day 1 and day 2, we had slightly different focus areas, but we really wanted to highlight really where we need to be focusing and considering moving forward. In the inequity piece, we all talk about that. I think yesterday really brought it home to us, is how do we really, there are still significant gaps in hypertension control across communities, across ethnicities, and across genders. So I think, really thinking about how the Roundtable can prioritize that will be a priority for us as we go and plan moving forward for 2023. And then today, hearing about innovative partnerships. We can't do this alone. There's no one organization or one sector that will be able to achieve this alone. Today's panels really highlighted the critical nature that we've got to be collaborating together in order to really see sustainable change. And I know it's really hard work in having managed coalitions, having managed collaborations in the past. The panelists from both panels didn't have as much time as they probably could have talked about all their wonderful work, but I know it's incredibly hard work and what they all were able to achieve. So again, kudos to all the panelists today. But again, going back to you all as a group, what have you heard from the panelists today around innovative partnerships to improve hypertension control? Were there aha moments? What captured your attention? I'm opening that up to the group.
I'd like to make a comment. I was on yesterday and again today, and a lot of work, and I know research goes through Medicaid and programs like that, but as a senior, I'm hoping that maybe some of these things can be collaborated with Medicare. I know, a lot of changes come in, they have exercise programs, and of course the new thing about having to lower rates. But one of the areas that never seems to get addressed, and I think I brought it up yesterday too, most programs do not allow Medicare recipients to go to nutritionists or dietitians if they don't have a diagnosis of, say, diabetes or anything. And because so many of us are living longer, there's a lot of people over 100, it would be great to have more help in that area so we can continue to grow into our 90s and 100s, but healthy with food programs. And not just, and I know some of you commented about home delivery, not even talking about that, but just that so many of us are at home. We still cook. We still, do our own food, and would love to see that Medicare would cover that so we could, go maybe even it's just once a year to get the right direction for how we should be eating.
Thank you for sharing that. And I don't want to rephrase what Dr. Wenger said yesterday, but I think she did make a point about that. It's just because you're aging doesn't mean you are supposed to have hypertension. So I think that's an incredibly important point. So thank you for sharing. Scott, I see your hand is raised.
Mute. Yeah. So I really enjoy this. A lot of great ideas. Two things. One is it sounds like we're getting some ideas out there that are shaking up status quo. Again, doing the same thing over and over again and expecting a different result. We're not doing that. We're trying to do something different. And that really, again, to probably channel my inner Janet right here, is to what are we going to do? What action are we going to take? And how do we move forward to try to get some of this stuff implemented? Because there was a ton of great ideas. Really excited about that. Now we have to figure out ways to get stuff implemented.
If there's one thing that, yeah, go ahead, Steve. Go ahead.
Oh, sorry.
Please.
I just wanted to address Elena's comment that, obviously as the older you get, the more illnesses, unfortunately, we come across. And I think it becomes an issue of polypharmacy, multiple medications. Something that I failed to address earlier when the question was asked about adherence is the fact that we've tracked what are our pharmacists doing with medication management in patients with chronic diseases. Is it all about polypharmacy? Is it all about adherence? I can tell you that it's not. We collected, for example, 67,000 interventions among 6,000 patients in that Center for Medicare and Medicaid Innovation Program. We found that a third of the Medicaid-related problems that pharmacists are addressing have to do with selection of drug therapy, optimization of dose, and even indications that weren't being treated. So I bring this up to say that one of the solutions that I like to see deployed more is making sure seniors get at least annual checkup to make sure that their medications are safe, effective, right dose, right combinations. In a year's time, a lot of changes happen when you're older in terms of your status of health and your mix of medications. So something that is on the wish list for what we can do for seniors.
Thank you, Steve. Hattie?
Steve and I talked about this recently, which is there was a study that came out of the European Society of Cardiology on the poly pill after a heart attack. And I know that we're not working specifically on that moment, but it was a very big finding of reduced mortality. And so with the resistance to the poly pill, what Steve was saying is the best approach, and Steve, I should just let you elaborate here, is that first you optimize exactly what that patient needs, and then you can use a pill pack. So we're looking for practical solutions that are going to increase adherence to the right medication optimization package. Go ahead, Steve.
So sorry, I was messaging my good friend Sandra Leal. I think what Hattie and I were referring to is the polypill concept showed that you take away the barrier of complex multiple medications and you get some results, some benefit. And I don't think anyone doubts that there's something positive there. But we also want to make sure that patients get patient-centered care, therapies specific to their disease states, combinations, tolerances. And sometimes what happens is when you give a patient a combination drug therapy, they experience a side effect, and now you're trying to figure out, okay, which pill was it that caused it? Sometimes it's obvious, sometimes it's not. So what we do with our work in comprehensive medication management is we don't immediately throw in combination drug therapies. We titrate and adjust each medication to its optimal dose, and then once patients get stable, that's the time to do the bubble packs and the pre-filled meds and make life really easy for patients. But at least in the initial phases, and Jaime said it very well, it was very active titration of medications. It is, sometimes there's weekly changes to drug therapies, and in those phases, pre-fills and bubble packs don't work very well.
Thank you, Steve. Modele, Janet was asking you Medicare coverage of nutrition classes, federal hypertension counselor, million hearts, ? I don't know if you want to respond to that, Janet.
Yeah, thank you. And so good to be back with you all today. So I I don't have an answer, Modele, to that question. And we know that with any of the federal levers, it takes a huge amount of time and focused effort and clear communication and consistent messaging from external forces, and a business case. But, anyway, there's all of you know, there's a lot of work that goes into changing policy for Medicare, Medicaid. But we also know that the impact of those changes can be huge. So it's all worth it. I do know that Medicare in particular is very interested now, obviously committed to health equity and to addressing the social determinants of health. Their levers for doing so are several. And again, all of them will take some time. So I think the job of this group, and certainly on the CDC side, our job is to surface that evidence or to find gaps in our knowledge and try to fill those gaps with new science to make the case. So all in favor of that. My editorial comment, or my more observational comment from working with the Federal Hypertension Council for the last 2 years, is that there is a strong commitment among members of the Federal Council to not just control, but also prevention and detection. I mean, we really started that council with a focus on control, and people said, wait a minute, we got to turn off the faucet. There were real public health themes within the members of the council to try to focus on prevention. When we got down to the activities, the actual actions, we started to find that the Department of Health and Human Services was not necessarily awash in the things that would help best with prevention. Yes, NHLBI and NINDS can help flesh out our evidence base, and there are parts of CDC that have focused for years in partnership with many of you on physical activity and nutrition, and we clearly can bring that to the table. A few other places around the department, but when you're talking about preventing hypertension and getting at the social determinants, you need DOT, you need USDA, you need other departments than HHS. So I only tell you this to say, I went into it thinking we were going to make real headway in prevention and detection. We're not giving up on it, but we need a bigger federal table in order to really have that impact. So we're pursuing people to sit on the council from departments outside HHS, and we know the VA has a lot of expertise in this area and hope to bring them in. Again, we're all playing the long game here and looking for the nearer term wins, as somebody here, as Scott pointed out. Over.
Thank you, Janet. Hattie had a question. I don't know who it's to, but maybe the larger group is, how can we leverage the findings out of ESC on reduced event rates among MI survivors if they're on the poly pill? Does anybody have an answer response to that one?
I think what Steve and I were just saying is that in the American context, we think that we can even, let's look at it before the MI or the stroke and take that learning about what it says about adherence, and let's optimize that individual patient's medication regimen, perhaps with a clinical pharmacist that specializes in this, and then create perhaps a blister pack or some other mechanism to enhance their adherence.
Mm-hmm. Thoughts on that? Comments? So let me ask the group after these last 2 days, what inspires you from hearing this? I know we have a lot of work to do, and we have a lot of work we have to continue to do, but what inspired you from the last 2 days?
Hey, this is Eduardo. I'll just start where I started this morning. The possibilities are in front of us. And part of what we can do as a roundtable is to create the coalition of the willing and able and begin moving the needle a little bit further along. I think it's clear it's not for lack of science, and there's so much that we can do right. There's some great ideas. Some of them will take an act of Congress or even more, and that's a heavy lift, but that can be part of our long game. And then the shorter term game is beginning to figure out how we can take some of what we heard about what's going on in communities, and at the very least elevate those stories and create the interest on the part of others who are trying to figure out what they might do at a community level to make those things happen. And when I think about yesterday is how do we take this message to, you know, what have been described by some as the chief health officers of all households, to not only appreciate what the effect of hypertension is on women's health, but how important it is for all of us to be in the business of making sure that that gets identified and controlled. So I'm inspired by the possibilities, but maybe a different part of the inspiration is that even now, there are 65 participants that are playing this game, and I have no doubt that when we come together, there will be more. And the other thing is there's a couple of other Pelotons out there. If we can in some way begin to identify that there's a handful of Pelotons working towards the same thing, we'll get where we're trying to get, I believe.
Well said, Eduardo. Yeah, well said. Thank you. Let me just say a couple of things. I think the inspiration is there, the passion is there. What I see coming out of these 2 days is the opportunity to tie a lot of loose ends. It may not be that loose, but tied a lot of different skill sets. So one aspect that I think we need to bring into anything moving forward is execution. Number one, and being pragmatic. And being pragmatic means we need to move from that idealism to the pragmatic world and said we need a better business case. We need to prove that preventative measures work and in what period of time. So we need to convince people that it's not just about ideally, or this is what this study showed, and that eating healthy is a good thing. Really is let's just be pragmatic and let's just be put the case, say what the value is, convince that those who make those decisions at a federal and private level, and then move forward. And then lastly is the operational execution. We need to be extremely mindful and picky about execution, because great ideas will never happen if we don't ensure that they happen, that they're that on the ground. So there's a lot of value in the people who actually make things happen down in the community. And I think speaking of the community, that's the other phase. So that the two next phases are let's move care to the community where people are, and the other one is let's be innovative. Let's just not stick to what we're doing today. So a lot of good things. I'm extremely feel very energized because we know that in order to do that, we already have the group of people who want to make it happen and will make it happen.
Thank you, Jaime. And I will add to that, yes, and if there is anybody that's not here that should be here, let's invite them. Because there's a lot of seats at the table that we are willing to add. And I think that's a great point, Jaime. We have such an amazing group of experts on this call today, but there's probably more out there. So if anybody has any organizations or individuals who are, you know, focusing on hypertension control, please reach out to them. We encourage you to invite them to join this dialogue and this action-oriented roundtable. Jim, you have your hand raised?
Yes, thanks for this opportunity. So there's a couple of things I want to add. One thing is an urgent question about some patient have the blood pressure monitor, could be Omron's, could be others. The tool is very important, but the question is how to validate a device, individual device. So that's a very common question. And I saw that because individual device is not like the validation is based on 85 subjects in a very specific protocol. And so because there's a diversity in among different people, so that's why we need a pool. So for individual device, the thing to check is number one, if the device is a validated device, That's a very good way to start with. Second is to check if the device, the cuff, is wear or tear. Because if the cuff or the connector or the cuff has some wear tear, there's some leak, then the device is no longer going to be valid and need to move on to either replace that cuff or have a new device. So that's very critical. Another point I want to address is we need to make things very simple. So I love the idea of this first titrate the patient with the right medication combination, and then try to offer this polypill so that it's much easier for the patient to take one polypill instead of 5 or 3 different pills. Make things simple always better. 3 is to get a validated device so that the patient can see the results and then can encourage the very good behavior. The third part I want to address is, as you mentioned, what inspired me. So the thing inspired me is I was very happy to meet with Eduardo, and he gave me this very nice souvenir, the essential 8, right? So for patients' care, hypertension is just one area. So it's about the good sleep, the good diet, the exercise or activities, about glucose, cholesterol, besides hypertension. And also another piece is in order to control hypertension, the diet is very important. Besides the medication, besides the monitoring or activity, and how to reduce the sodium intake, or how to replace the sodium with potassium. There is a great papers recently published about China study that's showing that replace only 20% of the sodium and can substantially reduce hypertension or the blood pressure. So the thing inspire me is to provide as easy as comfortable blood pressure for everybody. Number 2 is the blood pressure monitors is also qualified as a FSA, flexible account spending. So that is also the patient can take advantage of. And 3 is, as I mentioned, the sodium is so important in reduce the blood pressure and associated with diet. So I am working with Omron, try to make some meters, like we call the sodium potassium ratio device, make that available together with the blood pressure monitor to truly help the people to optimize their diet, because unless they can see it, they probably won't do it. So that is something I want to comment is, it's a holistic picture and we need to tackle this, and Omron want to be a part of it. And I will share my contact information for anybody has some needs on blood pressure monitors, on sodium, potassium ratio, or on any topics. I want to be part of it, support it, and to be a family in this battle against hypertension.
Well, welcome to the family, Jim. Thank you for that. I see a lot of nodding heads, so you are more than welcome to join us, and we are so excited to continue our conversation and our partnership. Modele, you have your hand raised, and I just also want to acknowledge, John wanted to acknowledge what Janet said in the chat box, so we can get to maybe after Modele comments.
Thank you, everybody. I think I am most inspired by the passion and the engagement of all our participants, and bringing us back to the theme of the summit, Act for Equity. I think that all the discussions we've had today and yesterday are all grounded in the basis for equitable patient care. But I want to draw our attention to a couple of things. I think a theme that has run through our discussions include: 1, everything we do should be centered around the patient and their families. I think that today we heard from the employers and the employees about simplifying the message. Perhaps it's time to think about a mode of communication. You know, hypertension, should we be saying high blood pressure to the lay public, to the patients, to the employees? Should we, if you think about the smoking campaigns, if you think about ads we see on TV, how many times do we see high blood pressure as a silent killer? You know, so I think that that's one thing to think about. How can we simplify messages? Another thing that has run through is the importance of addressing social determinants of health. And I think that a new way to think about healthcare, taking the management of hypertension and other cardiovascular risk factors to where people live, play, work, and pray. I think that and thinking about innovative ways to do it, thinking about Jaime's discussion about leveraging technology in a way that it doesn't exacerbate disparities. I think all these themes have run through our discussion. So I'll encourage us as we leave to keep the momentum going. Like Jenny said, join us at the Hypertension Roundtable. We will definitely be asking for your contributions, and always think about how can you ask for equity. We have individuals here, you're representing organizations. We hope you will take back that message and come back to us with actionable steps, to move this forward and decrease the prevalence of hypertension through prevention, detection, and achieve increased hypertension control rate, or maybe blood pressure. Is what we should talk about. High blood pressure. Thank you.
Thank you, Modele, so much. Thank you. And Janet is applauding you. That was so perfectly well said. Mohammed has his hand raised, and then Eduardo.
First of all, Dr. Eduardo, thank you for inviting me over here. Janet, thanks for calling me up. And I love that he chose a sign that is cultural relevant. So who is brown person? I clearly did not. And so in my emphasis on here, I represent an organization called Inn of Cares. I'm the founder there. We provide culturally competent care for moms and their babies. And one of the discussion was it takes a village, right? That's what I learned from this conference. It really takes a village. And hopefully on a macro level, we take that as well into our communities. At Inn of Cares, we really focus on that. It takes a village. It is connecting the moms with each other. We call what we call health tribe. It allows for the moms to share amongst each other like different conditions in that health tribe using telehealth, and as well as remote patient monitoring. They engage with each other, sharing data. And if they can share personal information with each other that's not that's much more confidential, they also post on our dashboard our doulas, our physicians go in and answer, right? So it's really that community engagement, that peer-to-peer, the importance of peer-to-peer support amongst moms, and as well as using the lemon community health workers for telehealth can really, and remote patient monitoring can really create an impact in solving this hypertension and preterm birth and diabetes challenge that we have with our moms. And by the way, I started this company because of my sister who passed during childbirth, so it's very personal to me.
Thank you for sharing, and I'm so sorry about that. Thank you. Eduardo, I think we'll leave it with you, and then I'll see if Modele wants to provide last mark, or Eduardo Modele want to provide last mark.
No, that's a high bar, but I will take that. There's a couple of things to share. One, I'm brown and proud, but more importantly, it's Hispanic Heritage Month, everybody. So vayan y celebren, por favor. El orgullo latino vive. So I'm not even going to translate. I'm going to force you to go figure that out. But it is Hispanic Heritage Month. We are a multicultural organization. This challenge is one where we got to pay attention to some of those factors that might help us figure out whether it's about messaging or execution or where we go, et cetera, and so on. And I say that because where I really started, what I wanted to share with you guys, I'm going to put it in the chat. You may have seen that in July, Morgan Health commissioned NORC to do a study of adults who have employer-sponsored insurance. And the bottom line is that even for folks with insurance, the impact of income and household income is astounding. And so in that analysis, persons from all groups, and some groups are more represented than others in the low income categories, whether it is about delaying medical care, not taking medications because there's no money, food insecurity, having depression, anxiety, or stress, degree of blood pressure control, all of those are tied to income levels. I bring that up because as we think about solutions even within settings like the employer setting, there may be opportunity to think about how to apportion resources and or activities in ways that in the name of equity get us to where we want to be, which is a high level of control for all, but which may require a little bit more for some than for others to get us there. So I'll share, I will thank everyone who participated today. Thank everyone who participated yesterday. Thank everybody for all the work you're going to do with the National Hypertension Control Roundtable, either as members or partners or affiliates or allies, whatever it may be. And Jenny, you and your team, congratulations to you for making this happen. It was a great 2 days. Modele, I am going to hand it off to you.
Before she does, I'm just going to say while Modele gives last remarks and where we're going to go in the next year, Annie's going to post a SurveyMonkey link in the chat box and encourage you all to fill it out. Again, it's another short survey, but I also just want to note that this conversation yesterday and today is only the beginning of where we're going to go for 2023. I have a lot of notes. We recorded this. We will send out the recordings next week to everybody who signed up on the registration link and is on the calendar invite. But know that there's a lot of work for all of us. So I am inviting you to truly join us in creating our focus, our strategy, the movement that we're going to create next year in 2023. To my executive team and the steering committee, know that we will have lots of planning sessions coming up in the next couple months as we really try to figure out, exactly what our area priorities are going to be around inequities and innovative partnerships. So thank you all so much. I'm going to pass this over to Modele, but truly join us. We would love to be working with you.
I don't have much to say. Well said, Eduardo and Jenny, but thank you all so much for your engagement, for your participation, for making this truly one of the best virtual meetings I've ever attended. I mean, the engagement, the coordination, people being respected of, respecting other people's opinions and join the movement. What are you going to do? That's the charge I'm leaving you with you and your organization. What are you going to do to make sure we have equitable outcomes in hypertension control? Thank you to Jenny, to Anne, to Rachel, and to everyone who joined us. Special thanks to Janet Wright from the CDC, my co-chair, Eduardo, and I have to recognize John Clymer, who has really been behind the scenes moving this forward. So thank you, everybody. Godspeed, and join us as we achieve equitable outcomes for hypertension control.
Thank you, everyone.
I wanna be the girl, I wanna kiss you right, I wanna drink that smile, I wanna feel like